Hello, my name is Dr. Ulrich. I'm here together with my colleague Dr. Sven Bräunlich. We are from the vascular medicine team in Leipzig. Both of us are interventional angiologists with a focus on peripheral interventions in the iliac, FEMPOP and BTK segment. We prepared a case for you with an iliac lesion and SFA lesion, and Sven will introduce you into the case.
Thank you, Matthias. We have here a 62-year-old male patient. He's very obese, by the way. He presented with acute symptoms with cough claudication left after only short walking distance. He has already implanted 3 stents into the left SFA 6 years ago, and he had a re-intervention on the left side with DCB treatment of the instant occlusions or instant stenosis of the SFA, as well as implantation of an interwoven stent into the distal external iliac artery, as well as the common femoral artery on the left side. You see already here, this is the baseline angiography. So we decided here in this patient to come from the arm, a transbrachial approach, for several reasons. First of all, as we do our diagnostics always with duplex scans, so we had a very low monophasic flow on the left common femoral artery, and there was the suspicion to have an iliac artery occlusion on the left side. As I said, the patient was very obese. It was impossible to have a direct view with the duplex into the iliac arteries. And by the duplex signal in the left groin, I was suspecting an iliac occlusion, and that's why, so in these cases, we like to come from the arm, because then we have really a direct antegrade approach here to this occlusion. As you can see here, it turned out it was no iliac occlusion. However, here high-grade stenosis of the external iliac as well as the common femoral artery here in the previously implanted stent at the area here of the groin. And more distally, I hope we will see this later, also the SFA stents had significant restenosis in the middle portion of the SFA. So as we established already here, our brachial access with 6 French sheaths in this case, long shuttle sheaths, 90 centimeter long. So we are able also to treat at least the external iliac as well as the common femoral, as well as under the use with long shaft balloons, also the distal SFA stent stenosis.
By the way, there are some options to treat this here. So one option would be just to go for ballooning, especially the aspect that it's a long way coming from the arm. But here we decided for another treatment, especially this lesion in the mid portion of the SFA. For these interventions coming from the arm, you need long shaft devices, and you should a little bit handle the treatment with the material which you have on stock. That's why you maybe should plan a little bit after this angiogram what's the best treatment.
Yeah, that's true. Of course, you can also do another puncture here, either crossover or even antegrade. As said, this patient was so obese. I think antegrade puncture not safe here in this case. So crossover. The groins were also not the cleanest, so that's why we decided to do the whole procedure here from the arm, just to see how deep we at the end we can go. And again here, this is then the wire passage of the stenosis, of the instant stenosis. Our standard guide wire here is, as we intend also, whenever possible, to use a debulking device, is command 18 standard tip guide wire, which is some kind of workhorse here for me to treat this kind of lesions.
But I believe that this is maybe the Rotarex wire, and but at the end we had difficulties to pass, and you can exchange for every other wire. This long Rotarex device with the working length of 135 has an extra long wire. Can be a good option here, but the 300 command 18
Might be too short, yeah, if you use long shaft balloons. The Rotarex guide wire that comes with a long Rotarex 6 French device is longer than 3 meters. I think it's 320 centimeter. But you see, the Rotarex wire is also very useful because it's very stable. Yeah, it's made of nitinol. The core is nitinol, so it cannot kink. It's very durable. The tip is a bit floppy, which is good because it's atraumatic. If you use it during the maneuvering of the device, it cannot harm because it's a really floppy tip. However, sometimes to cross really organized occlusions, it's better than to use another wire, just your CTO wire, and then exchange to the Rotarex guide wire, like in this case. So also here we did a little bit pre-dilatation. Before the application of the Rotarex, only here. Approximately, we just use the Rotarex really to be able in the stent to remove as much material as possible. So again, here, this would be also a nice case for 8 French Rotarex. However, I need then, if you come from the arm, 8 French long sheaths from the arm, maybe
can be big for the
too big for the brachial artery. So of course we don't want to avoid any puncture site complications. And furthermore, the 8 French device has not the shaft length of 135 centimeter as the 6 French device. So that's why then we cleaned up first here proximally, and also here then the Instent high grade stenosis in the left SFA. You can see you can come relatively deep with the long 6 French Rotarex, even from the arm, as demonstrated here.
It depends also a little bit on the size of the patient, let's say, and maybe also the morphology of the aortic arch and the iliacs. If you have kinking, then sometimes you cannot come very distal. Sometimes you can reach up to the distal third of the SFA, so you should measure it before.
Yeah, of course, we prefer the left brachial artery, so the distance is definitely shorter compared to the right brachial, and you don't have to go completely through the arch. So this also potentially avoids complications.
But here you see that the Rotarex is going very deep into the area where the stenosis was, and we try with 4 hands to push the device slowly down, which is also coming from the arm a little bit difficult, not to jump forward, but always we have movements in the device to be able to suck some material out, atherome, thrombus, whatever is in the vessel located. And maybe here it's not so important compared to the crossover approach to have it always in movement, but you can also heat the device here when you don't move it.
Yeah, there's still some remaining stenosis here in the common femoral instant. So you can see here, but the SFA itself already has a nice lumen again and a good flow. Yeah, and again here after debulking with the Rotarex, next step, again, DCB as usual. Sometimes maybe with the DCB, because the shaft length here is 130, you might not reach out the very distal portion then of the SFA.
That is a 650 Lutonics.
Proximally, it's possible.
Yeah. You see distal, the double markers for the long devices, you have the distal double markers that you know that this is the tip and that you're not across with the balloon.
Yeah, but it goes relatively deep, actually, I think into the target area.
Yeah.
So, yeah, and then, as I said, standard treatment with DCBs. And we use the balloon also in the external iliac, like demonstrated here.
This is again a 6 millimeter balloon. Also with 6, you have to be careful in the iliac, and our patients are awake, that we can ask them if they have pain, if they feel something which can be helpful to avoid perforations. And then we increase the pressure and also the size of the balloons. There's still no embolization so far.
So perhaps you can see here the calcification. It's a severe calcification. So actually the stents, 6 years old, look not too bad. Here we went in with another balloon just to touch up, to give ballooning of the entire standard area with 6 millimeter balloons.
Yeah, this case you would like to end up with a perfect result, that you don't have to go in again in a short time span, because there's so much stents and so much punctures over the years. It's always good to fix everything in such a case.
Yeah, we put our patients on dual antiplatelet therapy after treatment with tracheal balloons as well after stent implantation. So we do it for 3 months, dual antiplatelet. There is no real general consensus how to make it, how to handle it. But it turned out that this is a reasonable approach for the post-procedural treatment, medical treatment.
Yeah.
That's the final result.
Which is very good.
Very brisk flow now. This is an unselective angiography. You must imagine that the sheath is in the iliacs. But considering this, it's a very good, very fast flow. Down to the foot. Again, also here, no distal embolization. Also, the patient, as I said, presented with acute symptoms. Yeah. So he had an acute deterioration of symptoms. So we did expect also some fresher material here, but as you see, with Rotarex and adjunctive therapy with ballooning, with DCB, a very safe and effective treatment was possible. Thank you very much for your attention.
Thank you.